Department of Oncology. He's the Assistant Professor of Hematology at King Saud bin Abdulaziz University for Health Sciences and a consultant in the Division of Adult Hematology Department of Oncology at King Abdulaziz Medical City Ministry of National Guard Affairs in Riyadh. Dr. Ayman will be talking about PNH Pathophysiology and Diagnosis. تفضل دكتور.
السلام عليكم جميعا. كيف الحال? I was given probably the worst task of talking about pathophysiology and PNH, which is probably something boring because it entails talking about complement cascades, which we have learned a long time ago in medical school. And now I'm trying to remind you with this. So let's go on. All right. So talking about PNH, what is really PNH, paroxysmal nocturnal hemoglobinuria? It's a chronic disease that is really life-threatening, that leads to end organ damage and impaired quality of life. It's a result of chronic hemolysis that is uncontrolled and mediated by the complement system. So we know PNH is used to be, or is still called paroxysmal nocturnal hemoglobinuria, but unfortunately it's not paroxysmal. It's a chronic hemolysis that can be exacerbated with paroxysms, especially during viral infections and other conditions. It's known, or it used to be called nocturnal, mainly because of the previous tests diagnosing PNH, that hematuria happens usually in the morning, thinking that the hemolysis happened at night, and that was it was called nocturnal. But in fact, hemolysis happens throughout the day, and it doesn't happen only in the night. Therefore, it's not nocturnal. And hemoglobinuria happens in PNH in only 25% of patients. In only 25% of patients upon initial diagnosis. So 75% of patients do not have hemoglobinuria. Dr. Ahmed talked about prevalence and incidence. It's quite rare disease. It happens in about 1.3 per million population per year. It affects all age groups, but the median age at diagnosis is usually about 33 years. It affects males and females equally. There is slight female preponderance in Asian countries. So let's go to the basics again. Understand the complement system to understand the pathophysiology of this disease. So the complement system is composed, or is divided into three pathways: the classical, the lectin, and the alternative pathway, where they all converge on C3 by forming C3 convertase. And this is known as the proximal pathway. So once C3 is split by C3 convertase, then forming the C5 convertase, leading to the activation of the terminal complement pathway, and at the end of the day, forming the membrane attack complex. So let's try to understand these pathways as much as possible. So the classical pathway is usually activated by immunoglobulins, IgG, IgM. And the first step is the split of C1 into C1q, CRS2. So this complex activates, I can point here, I guess. Yes, good. So this complex activates two complements, C2 and C4, forming C4B2A, that acts as a C3 convertase. C3 is converted into C3b and C3a, and the addition of C3b to the C3 convertase forms what we know as C5 convertase. C5 is split into C5b and C5a. C5a is an aflatoxin. C5b gets arranged within the terminal complement system components C6, 7, 8, and 9 to form the membrane attack complex. Now, the lectin pathway similarly more or less goes through the same pathway of the classical pathway, but the initial steps are slightly different. It's usually activated by mannose residues on the bacteria through the mannose binding lectin and the membrane-associated serine proteases 1 and 2 to form the activation process of C2 and 4, leading to the same process that we have just explained. Now, the alternative pathway is peculiar, where it is continuously active. It's similar to a car in the idle process that is on and you're not accelerating. So this is the alternative pathway, and most of the problems of actually PNH are related to this ongoing complement activation through the alternative pathway. So to understand this, I'm not sure if this is really clear. It should be. Anyway, so to understand the alternative pathway is different as C3 in an aqueous solution in water. It gets a conformational change by a tick-over mechanism known that leads to the binding of C3 with water to binding to factor B. I guess you cannot see it here. I don't know. Anyway, factor B binds here. Factor B is changed where the action site of factor D is opened. Factor D is a small molecule that is present in the plasma, and it's always active. The issue is the target is hidden on factor B. So once factor B is attached to this aqueous C3, the target or the action site of factor D is opened, where factor B is split into factor BA and BB. Now, factor BB, in addition to C3, forms C3 convertase by small quantities that leads to C3b and C3a. Now, one thing that I need you to remember, that the alternative pathway is continuously active. It needs two factors that are not needed in the other pathways, which is factor B and factor D, because this has an implication in the management. We will hear from my colleagues down the road about certain molecules that target these factors in particular. So because this is continuously active, C3b also opsonizes red blood cells, leads to what's known as extravascular hemolysis. Now, this complement cascade, if it continues, it leads to detrimental effects. So Rabb al-Alameen subhanahu wa ta'ala has created some breaks to halt this complement system, and there are many of them, and deficiency of any of these leads to a certain problem. I will just focus on those that are related to PNH, and then once people talk about AHUS, maybe talk about other factors that are inhibitory factors, mainly of the complement cascade, and loss of these ones leads to continuous activation of the cascade, leads to the formation of the disease itself. So decay accelerating factor, CD55, known as CD55, and CD59 are two molecules that work mainly on the decay accelerating factor, or CD55, works by stabilizing C3 convertase. So C3 convertase is less active in the presence of DAF or CD55. CD59 is extremely important in stabilizing or in inhibiting the formation of the membrane attack complex at later stages in the complement system. So how is this complement system related to the pathogenesis of PNH? Now, the first problem, or the inciting point, a mutation that happens is a somatic mutation that happens within a gene called PIG-A gene. That PIG-A gene product is important in the synthesis of something called a GPI anchor. The GPI anchor is something that is present on the red cells to anchor different proteins. Now, there are many mutations that has been discovered in the PIG-A gene, about 180 mutations. Some of them are deletions or certain mutations, but the type of mutation does not really signify the clinical presentation of these patients. So a mutation within the PIG-A gene, which is present in the X chromosome, leads to the no GPI anchor, and therefore when there is no GPI anchor, there are no anchoring proteins that can hang themselves on this GPI anchor, and red cells are devoid of the anchoring protein and the other important proteins, among which are two important proteins that I have just talked about, which are the CD55 and CD59. This is how it looks. This is the plasma membrane of the red blood cell, CD55, CD59, and the anchor protein. As I said, DAF, which is CD55, is important in stabilizing the C3 convertase and marrow membrane inhibitory of reactive lysis. That is the old name. Now everybody knows these as CD55 and CD59. This is how the terminal complement pathway is formed by splitting C5 as the initial step in the terminal pathway, assembly of these different components of the terminal pathway, and then C9 forms a ring-like structure. Like it's like a drill that digs holes within the plasma membrane, leading to lysis of these RBCs. CD59 is important in inhibiting this C9 assembly to form the membrane attack complex. So lack of complement regulatory proteins leads to chronic uncontrolled complement activation on the red blood cells, leading to consequences of PNH, hemolysis, nitric oxide depletion, thrombosis, and others. So what happens on these red cells when they are devoid of CD55 and CD59, the regulatory proteins, and then lysis happens? What happens then? So lysis leads to hemolysis and liberation of free hemoglobin, and nitric oxide is a scavenger, so leading to reduction in the nitric oxide, and this hemolysis leads to end organ damage, for example, chronic kidney disease and pulmonary hypertension. Nitric oxide depletion leads to smooth muscle dystonia or dysfunction, leading to, I'm having problem with this, but that's fine, to dyspnea, dysphagia, erectile dysfunction, abdominal pain, and then activation of leukocytes, platelets through C5a in addition to the complement leads to increased risk of thrombosis. as I mentioned, I mean, so many problems happen secondary to the hemolysis that impact survival or create certain morbidity. This is ما أدري كيف طالعة بس that's fine. This is just to explain that this has been alluded to by Dr. Ahmed earlier, which is the extravascular hemolysis that happens in PNH in addition to the intravascular hemolysis. Now, extravascular hemolysis is thought to be formed mainly after C3b opsonizing red blood cells. And these red blood cells, after opsonization, they get engulfed by the reticular endothelial system. So the mechanism of hemolysis in extravascular hemolysis is totally different than intravascular hemolysis, which is complement mediated. Although there is complement opsonization of the extravascular hemolysis, but it's the macrophages which engulf these RBCs in the spleen and the liver. And we know it's a fact that the exaggeration or the formation of what's happening in the extravascular hemolysis increases with terminal complement pathway inhibition. We know that thrombosis is the leading cause of death in PNH patients, and the risk is high. About 40% of patients develop thrombosis, and this is just to show you the risk of thrombosis compared to a normal subject or a normal human being. So if you have only high LDH, more than 1.5 upper limit of normal, you have 7 times risk of thrombosis. And in addition of this high LDH, if you just have an abdominal pain, then that risk increases to almost 18 times, and chest pain 19 times. Chronic kidney disease is common in PNH that is related mostly to the free hemoglobin and hemosiderin deposition and depletion of nitric oxide. In addition, pulmonary hypertension is also common in about almost half of patients, and it happens secondary to the microthrombi that can form in addition to the nitric oxide depletion. So far, talked too much about pathophysiology, just to wake you up. So PNH is a progressive life-threatening disease that causes thrombosis as the leading cause of death. The complement system plays the major role in the pathogenesis of PNH. It's a result of a mutation of a gene that encodes for the GPI anchor protein, leading to the loss of the regulatory proteins CD55 and CD59 in controlling the complement system on the red cells. Enough with the complement system. How do we diagnose PNH? Now, unfortunately, as you can see here, this is the list of symptoms that patients present with initially when they are diagnosed with PNH. And as you can see here, none of those is really specific or pathognomonic that you can say this patient has PNH. Fatigue, anemia, shortness of breath, abdominal pain, erectile dysfunction, dysphagia, all have multiple causes. Traditionally, PNH was known to have a triad of hemolysis, thrombosis, and bone marrow failure. But that depends on whether this is classical PNH or PNH plus. We'll talk about this in a little while. So there are different authorities. The PNH Interest Group and the International Clinical Cytometry Society have developed guidelines on which patients we need to test for PNH. And CATCH is a mnemonic that can help you remember which patients you need to test for PNH. C stands for cytopenia. So on patients presenting with unexplained cytopenias, you need to test them for PNH. Aplastic anemia, all patients who have a diagnosis of aplastic anemia need to be tested for PNH. Thrombosis. Not every patient with thrombosis you need to test for PNH, otherwise we'll be testing lots of patients and come up with a negative test. But thrombosis in unusual sites that happens without an obvious risk, such as Budd-Chiari syndrome, for example, you really need to test for PNH. Patients who present with hemolysis, and this is the commonest presentation of these patients, anemia secondary to hemolysis. And hemolysis is defined when we have high LDH, high indirect bilirubin, high reticulocyte count, and absent haptoglobin. Patients usually have Coombs negative hemolysis in PNH. But something to warn you about this, most of these patients, usually, they have had already blood transfusion. And sometimes blood transfusion can give you, because of alloimmunization, give you positive Coombs test. So don't be, fooled with a Coombs positive hemolytic anemia, not to be PNH if your patient had already had blood transfusion. Hemoglobinuria, of course, one of the pathognomonic or the rare symptoms that can happen in PNH. This is what I told you earlier. PNH overlaps with other diseases in hematology, namely aplastic anemia and MDS. In MDS, it's especially the small percentage of patients that what we called hypoplastic MDS because of the hypocellular bone marrow upon testing. Now, when patients have PNH alone without aplastic anemia or MDS, they are known as classical PNH. And when patients have, in addition to the PNH clone, a problem or a hit to the bone marrow that leads to either aplastic anemia or hypoplastic MDS, we call them PNH plus. And it's about almost half the patients have classical, almost half have additional disease in the bone marrow. This is just to show you that the PNH clone actually, tiny PNH clones are very common in the population, but they don't form anything. Now, when there is a secondary bone marrow hit that happens either by the autoimmune system in aplastic anemia or myelodysplastic syndrome, then that small clone takes an advantage and becomes larger and becomes the main clone in the red blood cells, leading to the problems related to PNH with hemolysis and other problems. How do we diagnose PNH? I mean, historically, there has been some tests that are obsolete by now, and the most widely used test is flow cytometry. And flow cytometry mainly looking at CD55 and CD59. This is flow cytometry in red blood cells. So red blood cells are classified based on if they have CD55, CD59 into type 1, type 2, type 3. Type 1 is the normal red cells that have normal expression of CD59. Type 3 are red blood cells that do not have any CD59 expression. And type 2 are in the middle here. They have partial expression of CD59. And PNH patients have, of course, type 3, and some of them have, in addition to that, type 2 red blood cells. But the diagnostic test of choice is flow cytometry by FLAIR. FLAIR is what is known as fluorescent labeled pro-aerolysin. Aerolysin actually was discovered. It's a toxin secreted by a certain type of bacteria. It has the ability to bind to the GPI anchor, which is the lost protein in PNH. So this flare is added to the tube and then looked for by flow cytometry. This is for hematologists. I don't know. This is how we do flow cytometry. We classify cells based on side scatter and CD45, based on granularity and size. Anyway, these are, I mean, we do the test in monocytes and neutrophils that can help in the diagnosis. This is normal peripheral blood. As you can see, monocytes, when they are in the right upper corner square, this is positive for both. So it's positive for flare. This is positive for flare. In PNH patients, you see two clones, and this clone is the PNH clone that does not have the GPI anchor, and here in neutrophils, it's the same one. I'll not talk about management. I guess other speakers will elaborate on the management in details, but historically speaking, patients, when they were used to be treated with only supportive care, almost 50% of these patients died within 10 years. So this is my last slide, take-home messages. PNH is a progressive disease with common signs and symptoms. It does not have a pathognomonic sign and symptom. Chronic hemolysis is the underlying cause of progressive morbidity and leads to affects quality of life of these patients. Thrombosis is the leading cause of death, in addition to chronic kidney disease, pulmonary hypertension, and others. Historically, if untreated, leads to death of half of the patients within 10 years. With this, I conclude my talk. Thank you very much. I guess we have a panel discussion later on. Okay.
Thank you, Dr. Ayman, for this extraordinary presentation. Thank you very much. Now moving, our third speaker, Dr. Hatoun, she had an family emergency last night, so she